Good morning. Would like to thank the ACC and JACC case reports for the opportunity to discuss an exemplary case report describing the complex management of a ventricular arrhythmia patient with a valve lesion. I have the pleasure of being joined by Dr. Bill Stevenson from Vanderbilt University Medical Center. I was fortunate enough to have been Dr. Stevenson's fellow a little over a decade ago now, and it's a delight to be able to talk to him about this case. This is really an opportunity for us to learn from Dr. Stevenson about how to put a case together, how to make decisions, and how to write cases up for JACC case reports in preparation for a special issue featuring Asian electrophysiology cases and JACC case reports. Dr. Stevenson, welcome.
Thank you very much, Jeff.
So this is a case that you published with one of your colleagues in interventional, a patient with ischemic cardiomyopathy and severe aortic stenosis, presented with VT storm and had a very high risk presentation for VT alone. Forget the hemodynamic lesion. It was if we follow the Payne's D scoring system for ventricular arrhythmia risk stratification, this was a very high-risk patient, made all the more so by the valve lesion. How did you approach this? How did you put this case together?
Yeah, well, we had clearly to deal with two life-threatening conditions. And so we met with our interventional colleagues, who Dr. Lowenstern, who's very facile with TAVR. And together we worked out what would be the lowest risk means of approaching this situation. If we attempted to do a VT ablation and we got into trouble hemodynamically with cardiogenic shock in the face of severe aortic stenosis, we thought that would be very difficult for us to bail out. If they did the valve first, they were worried about getting into trouble with VT. The VT didn't bother us so much. We felt we would probably be able to control the VT, even though the patient required amiodarone and procainamide to maintain a stable rhythm prior to the procedure. So then coordinating that, deciding risk benefit, and then also involving our cardiac anesthesiologists to try and do this in the safest possible way. So communication and planning among the teams was really critical.
It seems that there's always this balancing act between trying to avoid hemodynamic compromise during a ventricular ablation, and certainly there's risk of that with any valve intervention. But you have to manage the risks up front, and it seems that the perception was that you could medically manage or shock or potentially cardiovert a patient with electrical instability during a valve procedure, whereas if you have hemodynamic collapse during the ventricular ablation, which can happen and was a significant risk based upon just the risk profile, you would have no bailout strategy. So this was well executed. Can I ask this though? What made you decide to do the valve and the ablation kind of in the same procedure versus maybe staging them, doing the TAVR first, giving it a day or two, and then going to VT ablation?
Yeah, well, we thought that even if we did the TAVR, the patient was going to continue to likely have VT, and to put him under anesthesia once, and then know that as soon as that aortic obstruction was relieved, he would be pretty stable. And then to be able to have access to the left ventricle via a transeptal approach, we don't have to go across that brand new TAVR. We thought that was probably in his best interest to try and do this in one fell swoop. Now, if the TAVR had become complicated, we were prepared to change our plan.
Sure.
But the TAVR went well. We were all prepared to deal with the VT, which indeed the patient went into VT as the valve was placed, and then went into VT again subsequently. Interestingly, when they did the rapid pacing to inflate the valve, the patient didn't go into VT during that was when we thought we would deal with it. And then once the valve was deployed, we were in good shape to proceed with the VT ablation in the usual fashion.
Did you modify your VT ablation plan, your mapping strategy at all after the valve was deployed? Did you
No,
truncate the procedure at
we
all?
didn't, yeah, no, we didn't need to do that. We went ahead and transeptal approach, mapped did a voltage map and substrate map of the scar, and then targeted the abnormal electrical activity within the scar, focusing on the regions of the scar that we thought likely contained the exit for the VT.
Wonderful. And how'd the patient do? How many days did they remain in the hospital?
Yeah, he did well. So over the next 3 days, he had a lot of accelerated idioventricular rhythms, but recovered very well. But we were worried about those AIVRs. So 3 days later, we brought him back to the lab. My colleague, Travis Richardson, did a stimulation. He had 2 of his 7 VTs were again inducible. So Travis did additional ablation for those, rendering him not inducible. He subsequently returned home and was recovering well and was back up and around and in rehab. It was really a gratifying outcome.
It sounds like it. It's so really emblematic of all the things I think I and others fortunate enough to have trained with you learned to be strategic, patient, and thoughtful in the engagement of patients, engaging other services to solve problems. And this goes back to some of your earlier work with engaging surgeons in the operating room or in the EP laboratory, to engaging interventional cardiologists like Piotr Sobieszczyk at the Brigham for alcohol ablation, and now it's gone to structural interventional cardiology colleagues as another example of how well you plan procedures. I'm really grateful to you for sharing this case with us and for continuing to teach us and push us to be better physicians and better electrophysiologists. So thank you very much, Dr. Stevenson.
Oh, thank you. It's been a pleasure.